Next slide. And each visit, maybe annually, every 3 months, or it may depend on patient. It can be patient specific. Now, the investigations routinely done are CBC, which are usually now done every 3 months. But reticulocyte count is very important. We do not pay much importance, which gives lots of clues. So reticulocyte count, I would stress that we must do reticulocyte count every 3 months, if possible. Hemoglobin F at least annually. Renal functions, liver functions annually. Pulmonary functions annually. There are few screen. Next slide. Few screening tests we should be doing now, and this comes under supportive. And I would stress, now we are seeing many organ involvement, multi-organ involvement. As the patients are, we are seeing them in second, third, and fourth decade. Most of them have at least one organ damage due to sickle cell disease. Every pain episode which a patient has is doing some damage to the organ. There is some organ disease and treated. We should be doing a screening test to prevent. We have preventive measures by which we can prevent, like stroke. I think the most morbid symptom is or presentation is stroke. Why? Because 12% of my patients will have stroke by the age of 12 years, and many of them have had stroke even for 5 years. And once they have stroke, I have not much to offer them. Even chronic transfusion, hydroxyurea does not help much. They have recurrent attacks of stroke. So that is very morbid. So one can do transcranial Doppler from the age of 2 years to 18 years. That is at least should be done once a year. These are specific tests which I want to stress upon, as we can prevent the organ damage later on. Microalbumin, though books mention that it should start from the age of 10 years, no. Our patients do from 5 years, because we have seen that 3% of our patients have abnormal microalbumin, raised microalbumin. So if we are we do creatinine ratio, albumin creatinine ratio, which is high, and we put them on treatment if it comes positive for 3 times. Pulmonary function test, not much problem with the pulmonary function test as much as nephro and stroke. Tricuspid regurgitation, yes, for pulmonary hypertension, and not to forget the importance of newborn screening. Next slide, please. This slide is just to show that we are not doing transcranial Doppler in India, but it is very easy and can be done, and I am doing till 2018. And I think there is a workshop in July SOCON where you can all join for TCD workshop. Now the next slide. Now, palliative management of sickle cell disease can be divided as supportive. Supportive is the most important, because if they have lack of sleep, just lack of sleep, they have a pain episode, VOC. Diet, they have to have balanced diet, sleep, hydration, and folic acid. I think these we just say very lightly, and the patients also take it very lightly, but it has to be given more importance. Symptomatic are mainly due to symptoms which they target, like transfusion for symptomatic anemia. Symptomatic anemia, mind you, not asymptomatic anemia. Analgesics for pain. Pain, we do not go with opioids as the first line of treatment. There are physicians in India who are giving opioids as the first line, and we have seen that patient becomes addicted very soon. A very city near Nagpur, the physicians have started giving opioids, but no, even in the West, now they want to come back to, like I started codeine, paracetamol, non-steroidal, anti-inflammatory, and then tramadol. So I think one has to be, and again, don't take pain lightly, take pain as a disease. Give antibiotics antibiotics for infection. Now, for prevention, vaccine is the best example where we have reduced bacteremia by giving pneumococcal vaccine and penicillin prophylaxis. And abortive is mainly what we talk about exchange transfusion for prevention of stroke. Next slide, please. Next slide. Now, blood transfusion I want to stress because I think this is the most thing I'm worried about, because inappropriate blood transfusion is happening everywhere. Even I have done before, but till the understanding has changed, hemoglobin is more the sole criteria to give blood transfusion. I want to stress here that we must always, I think one of the important thing I want to talk about the supportive management is see the test results when they are in the steady state, not when they come into crisis. So you have to stress to the patient that see, I'm going to treat during crisis if I know your steady state parameters. And one is to understand that even at a lower hemoglobin level, the tissue oxygenation in sickle cell is quite good. So unlike thalassemia, we don't want the levels to be 10. I never want my level to be less than 7 or more than 11. Both are next slide. Next slide. Now this is a very, next slide please, a very simple table, where we can see, I told you one of the very unique feature which our patients have is anemia. And so we have to look for other causes of anemia, like nutritional deficiencies, malaria, other factors. And thus simple CBC and reticulocyte count will give us hints about the cause of anemia, and we can treat accordingly. Next slide please. Now these are the indications, not that I say don't give blood transfusion, but give transfusions when they are indicated, because these are conditions when they save life. And when you give simple exchange, this chart is showing. Next. First time I think ASH has come out with recommendations against transfusion. Us having symptomatic anemia just because the hemoglobin is 6. I used to give blood before, but now no blood. It's the asymptomatic anemia, pain crisis which is uncomplicated. These are not the causes or reasons why we should be given blood transfusion. Next please. Now few things I would like to stress here. Next slide. We used to give IV fluids very often. As soon as the patient of sickle cell will come, even for pain, I will put them on IV. Now, it is said that you have to be very careful when you give IV fluids, because they can precipitate acute chest syndrome. They come for VOC, but then it can precipitate acute chest syndrome, which is a very serious condition and high mortality. So I try to give oral fluids, more oral fluids than give IV. Of course, if we are not able to take, give IV, but with proper monitoring and caution. Sodamine tablet, now we are not giving, because patient takes sodamine and not hydroxyurea. So unnecessary tablet, we don't give blood transfusion, I told you. Penicillin prophylaxis, yes. We give penicillin prophylaxis in the newborn screening program right from the third month. Or otherwise, any child below 5 months, we put them on penicillin prophylaxis, and if they are not able to take penicillin prophylaxis, we do give long-acting penicillin injections, still available every 3 weeks. The compliance is good with injectables. Pain management, I've already told you. Special vaccines, I think we know about pneumococcal vaccines, and it has come in our national program. Hemophilus influenzae, that also has come in the national program, hepatitis D. So most of these special vaccines are covered in the national immunization program. Meningococcal vaccines, especially before splenectomy, you must give meningococcal vaccination. About pneumococcal vaccination after 5 years. Yes, there are now proposals to give pneumococcal vaccines even after 5 years, but till now I am giving only till the age of 5 years, unless they are going to go under splenectomy. Next slide, please. Now the survival of children with sickle cell disease has definitely improved in India, definitely. But we do not have a national registry, so I cannot be very specific. But now it is, I would say, it would be around second and late second and third decade. Next slide. One thing is very important. When you are giving them care, supportive care, I think next slide please. It is very important that all things are under one roof, at least once a week or once a month. See the patient for radiology, they will go for pathology, they will go somewhere. We need an orthopedic surgeon, we need a surgeon for gallstone, we need a obstetrician for pediatrics. So I think everything should be under one roof. Next, please. These children are most of the children they leave school. Next slide, please. Next. So they leave school by 5th to 6th time because of that absenteeism. So they need boosting, and we have many competitions for them, and we boost up that you can do something, and they have to be doing something. If not studying, they have to sit at home, give exams, or do whatever it is. But that is the biggest problem which is coming now. Now, what is important? The supportive care. I think most of the time, it is the parents and teachers who are managing children with supportive care. Next slide. Can you please move the slides faster so I can be on time? This is a diagram I always show to my parents because they don't understand the importance of water. They do not understand. Madam, पानी नहीं पीता, हम नहीं देते. Why? If you give pani, this is not going to be blocked. It will move on. So it's such a simple thing they need to know. Another thing they always ask is, my child was AS, now he has turned SS. We have to stress that. Next slide. We have to stress that AS cannot become SS, SS cannot become AS. Next slide. We have to tell the parents. Next slide. Now talking of the supportive care for the parents and the teachers, that each organ can be involved. We have to tell them about the signs because they are different in different ages. You get dactylitis below 5 years, you get this sequestration crisis. We teach them about how to measure sleep because we see sequestration crisis even in older children, because splenomegaly, hypersplenism is there even in second decade in our population, which is different from other countries. So I think we have to tell them. Next slide. What are the phenotypes and how to detect them? Main thing is we must tell them how to recognize crisis. If they do it fast, they know what to do at home. Our supportive care, 50% of it is done. Give them water. Start treatment at home. Give paracetamol at home before even bringing to my clinic. I tell them that now we give them paracetamol, which we were not giving before. Next, please. And when to communicate with the medical professions, that they don't know. They must be told what are the red flag signs. Every time with different age, there are different red flag signs. They are not the same at every age. Next slide, please. I already talked about sequestration crisis, very common and a common cause of death, which can be prevented if the parents are educated properly. Now, this is a lifelong disease, and appropriate measures specific for the time, education, genetic counseling. See, while we are seeing the patient, we have to do counseling at the same time. Next, please. Friends, there are many important things which are comes under supportive, but I don't think the time is permitting me. Now, this is very important. The adolescents now go for alcohol in that group, and I've seen so many patients who have had sudden death because they enjoyed in a party, had more of alcohol, and they died. You have to explain them. If it's an adolescent, I always ask him, call him. See, your friends will drink. You don't have to. Okay? Yoga. This is a study, scientific study published that yoga and meditation, they do help in global sessions on sickle cell disease global meetings. We have sessions on yoga, meditation, and nutrition. So a one-day full conference, and we need to give importance to this. Next slide, please. Next. Yeah. Now this is my favorite slide because I think previous one. It is very important that these few things are always with the patient. The thermometer. They say just a bukhar. They must have a thermometer. They must have a diary in which they write everything. They should have a mask, a water bottle, a pulse ox, a spirometer. Spirometer exercise does decrease the severity of acute charge syndrome, and these are water resistant markers. Pen. which we mark the screen with this, so they know the splenic size in a steady state level. Next slide, please. Next slide. Rahul, just one or two more slides. Record keeping pain with this is very important, the severity of pain. We all must have dealt with this phases. Long Baker scale, which is the simplest, and they must do. My patients don't do well with the electronic diary. They need this diary to keep everything. Next slide, please. Next. Now the diary also has when they were admitted, how many blood, other things in this. So at a glance we can see everything. They have to bring the diary every time, which is in their sickle cell kit. Next slide. Next slide. I think the other thing we must tell the patients, next slide, is the initiatives which are given by government, because they are not aware of it. Next, previous, because most of them are not available that it has come under disability yet. They get free travel concession, they get investigations free, monthly they get some amount depending on the state. In examination they get an extra hour, even in the board examination. They have to be informed about this. This is not known to the patients, and it is important to inform. I think I'm going to stop here, Rahul. Thank you. Thank you.
Thank you, ma'am. Thank you so much. Dr. Rahul? So thank you so much. It was great, ma'am, to learn that what exactly patients are needing and how. As we said that we need to have a diary for the sickle cell disease patient. It's now important that if we come to, join the scheme of ABDM, now the patient doesn't have to worry about their diaries at least. They have their own history. Wherever the records are there in the hospital, they can take the records and then they can have their own diaries on their own. So that is the concern. And now this is a time when one should see that these are the issues which has to be taken care by the doctors, as well as the patients has to adhere with what exactly has been said by the doctors. So these two things which was very well said by Dr. Deepti, and it was nice, ma'am, to hear. As usual, it's a long life. Now if we have a good record of patients, we will be able to take care of our patients. Thus the health professionals will be very happy to see if somebody sitting in Agra have the records of, with the consent of the patient, if he or she can see the records in Agra of Maharashtra, that will be great. Suppose a patient is in Nagpur and comes to Agra and now the record can be seen. It will be very helpful for the patient. It's not for us. So now the concern is that one has to address these issues through ABDM. So that's what Dr. Basant Garg was talking about कि कैसे हम जो है अगर patients की direct पूरी हमें record अगर consent के साथ, but we take up with the patient's consent. हम बिना patient की consent से कोई काम नहीं करते हैं. तो अगर वो हाँ भरता है तो डॉक्टर्स उनके रिकॉर्ड देख सकते हैं और उनको पूरी अच्छी तरह से इलाज भी हो सकता है. इसी तरह डॉक्टर्स के लिए भी फायदा ये है कि उनको पता रहता है कि उनको क्या दवाएं दी गई हैं या अब तक उनकी क्या दवाएं चली हैं. तो जो नेक्स्ट कोर्स ऑफ एक्शन होगा वो बहुत अच्छे तरीके से लिया जाता है. दैट्स वेरी इंपॉर्टेंट. सो नाउ नेक्स्ट स्पीकर इज Dr. Manisha Madhaikar, who is director in NIH, which is one of the ICMR institute. And this is important. Unmute कर दो Dr. Rahul को please. Dr. Rahul को unmute करिए. फिर पोस्ट बनाइए उनको. नहीं फिर unmute नहीं हो पा है. So now this is over to you, Dr. Rahul. Over to you, Dr. Rahul.
Okay. So, thank you, ma'am. And it was a wonderful session by Dr. Deepti. Insight into sickle cell from the ground zero, what she has learned over past 4 decades, she has shared with us. And Dr. Vinita, that's absolutely right that once we have a digital record, it's going to change the way we practice so that we don't have to repeat, and the overall cost of treatment is going to come down. And we can actually monitor, as we say, national registry. Ayushman Bharat and Digital Yojana will give us an opportunity to have work as a national registry for thalassemia and sickle cell to understand as natural course of a history of a disease. Because still we do not know till now how many thalassemics are there in this country. Do we really know? We do not know. Until unless we do not have that data, we will not be able to serve the right people with the right resources. And keeping that in view, Dr. Mandekar from NIH has done a remarkable job in diagnosing and giving the country the diagnostic ability to not only diagnose sickle cell at a very affordable cost, but also rare genetic disorders. And NIH has been a lifeline for all of us in a country, again a government institute, which is a visionary thing, where the Roshan Kola ma'am and other people have actually contributed a lot to the understanding of hemoglobinopathies in the country. So over to Manisha ma'am.
Thank you so much. At the outset, sincere thanks to NHA, especially Georgie and Monica ji, for giving me this opportunity to be part of this important brainstorming session. And at the outset, greetings to all of you on the occasion of World Sickle Cell Day. What I'll be speaking to you is our experience, of course, as everybody talked about, Dr. Roshan Kola, Dr. Malay Mukherjee, Anita Natkani, who have worked extensively and have taught us, including me, and of course Dr. Dipti Jain madam, who has just given a wonderful talk based on her experience and the passionate work that she has done over the years in the area of sickle cell disease. So I will be sharing with you the important aspects of diagnosis of sickle cell disease. We have many tools for diagnosis of sickle cell disease and hemoglobinopathies. Which one to choose and how to interpret the results, and how we can diagnose or optimize the diagnosis and include as many patients under the care of these wonderful schemes that the government has started. I have been also given the topic of management, but I'll focus mainly on diagnosis, largely because we have stalwarts like Dipti Jain madam and Dr. Anupam Sachdeva, who will be talking on management. I'll just share a few of our experiences of conducting some of the studies like newborn screening program, as well as hydroxyurea clinical trial, and the challenges that we have faced in terms of management and probably where we need to focus our further efforts. So, can you see my slides?
Yes, please. Yes. We can see.
Is it possible to share it from my side?
Yeah, you can do it.
Can you see my slides now?
Yeah, we can see your slides.
Okay. So because it's easier to translate.
Yeah.
So yeah. So as all of us know that our Honorable Prime Minister has launched the National Sickle Cell Anemia Elimination Mission 2023, which has given a lot of boost to care of sickle cell patients, especially in a difficult tribal area. And this mission was launched largely because looking at the burden of the sickle cell disease in our country, we have the second highest burden of sickle cell disease in the globe, contributing to 15% of sickle cell anemia babies which are to be born every year. Many of them are difficult to reach tribal population. And as Dr. Dipti Jain just now said, that it is not only tribal population, but we are also seeing non-tribal population, especially economically or socially backward classes. But this is very important to understand that sickle cell disease probably is not uniformly distributed all across the country. It is there in few states, and within these few states, some of the districts which have a very high prevalence, and understanding this becomes very important when you want to target your efforts for an optimum achievement of goals of the sickle cell anemia mission program. So, if you, the primary objectives of sickle cell anemia elimination mission is to provide affordable, accessible, and quality care to all sickle cell disease patients, and to reduce the prevalence of sickle cell disease and sickle cell trait. And to achieve this, Ministry of Health and Family Welfare has come up with beautiful guidelines, and many of the experts are sitting here who have drafted these guidelines. And this gives you a roadmap as to how one has to go about if we have to achieve the goal of sickle cell anemia, or at least elimination by 2047, or at least achieve good control and comprehensive care for these diseases. So if we have to achieve these objectives, we have to first diagnose the patients with sickle cell disease. We have many tools at our disposal which are useful for diagnosis of these disorders. Right from simple solubility test. Solubility test is based on a simple principle that you have a buffer in which you put a few blood drops, and which lyse the red blood cells. And after the lysis, you can see that patients with sickle cell disease, you have, you cannot, the solution becomes turbid because of sickle hemoglobin is not soluble. Whereas in positive, in negative or in a healthy individual, you can see the black line with the solution is transparent because the normal hemoglobin is soluble. The advantage of this test is this is very cheap. Now you have ready solutions which are available. Stability of these solutions is also good. They are cheap, they are rapid, you don't need fancy diagnostic tools or equipment, and can be performed by at the periphery easily. And the results are available within 5 to 10 minutes. The disadvantage of there are few, however, there are few disadvantages. It cannot differentiate between heterozygous versus homozygous disease. And when your percentage is small, especially in newborn, because your majority of the hemoglobin at up to 6 months of age is hemoglobin F, and sickle cell percent even in a homozygous newborn will be very small. So solubility test will not be able to pick up homozygous cells very early in life. So, but however, for population this test still is very sensitive and specific. Then comes the sickling test. Sickling test is also based on a principle that you add to a whole blood, you add percent metabisulfite solution which precipitates sickling in a patient with hemoglobin S, and the sickle cell percentages of this sickle cell you can measure under a simple microscope. So what you need is a slide, cover slip, a solution to induce sickling, and and a sealer and a simple microscope to measure. So the test is simple, however this test is, requires a technician because you need to read this under a microscope and takes time. So this test is largely now restricted wherever you have on an electrophoresis an abnormal band in a sickle cell region to confirm that this is a sickle cell region. Then comes point of care test. What are point of care tests? And a lot of now we are talking more and more about these point of care tests, largely because they can diagnose sickle cell disease at a reasonably low cost. They do not require a specialized device or can be performed on a portable device. They give accurate results. There is no instrumentation, electricity or refrigeration that is required. And you can measure the result visually, and you can qualitatively use the results. The most common point of care test that are now available and are very useful are basically lateral flow immunoassays. So these are like a simple pregnancy test. You have simple strip-based assays. You need to put just few drops of blood into a solution, lyse the cells and put it in these wells that are available on these strips. And what you will see is at the end of it, different lines which you need to interpret. So they use highly specific monoclonal antibodies against hemoglobin A, hemoglobin S, and some of the international kits also use monoclonal antibodies against hemoglobin C. Because hemoglobin C is common in the African countries and other countries, but it is extremely rare in our country, and that is the reason why we are not insisting on having hemoglobin C within the point of care test. They can detect sickle cell disease as well as carriers with a sensitivity and specificity of nearly 98 to 99%. And initially what we had is only international kits available in India. Hemotype SC and sickle scan which was available, which were expensive. Each one of these strips used to cost at least 250 to 300 rupees. But I'm happy to share with you that because of our insistence on Make in India products, now we have many companies who have successfully produced strip-based point of care tests for sickle cell disease. And now we actually, ICMR institutes, along with, especially our institute, has been recognized by DGHS for validation of these kits. And in last 2 years, we have validated more than 12 such kits. I'm happy to share that nearly 7 to 8 of these kits have passed the required sensitivity and specificity criteria and are really good for rapid diagnosis of these disorders. Since they are specific monoclonal antibody, if the sickle cell disease is detected, the diagnosis is kind of certain, and you can initiate the management based on this, though the confirmation with molecular techniques needs to be performed. So these are rapid, specific diagnosis, but they can be used for diagnosis of sickle cell disease. Even for newborn screening, they have been found to be useful. So we have actually under our newborn screening, multi-centric newborn screening program, tested in each center 300 samples with the use of test phenotype. We have found that the results are matching the experiencing. The point of care test can be easily used for newborn screening as well. Then comes a simple technique, cellulose acetate electrophoresis. This is a very traditional technique being used for now many years by many laboratories. This electrophoresis is also available under thalassemia program at multiple district hospitals also. But so this technique actually separates under electric field the different hemoglobin components that are there in the red cell. And if you have a sickle cell bomb, which clearly tells you that this is a sickle cell disease, and this technique again is simple, the equipment is cheap, and however you need technical expertise if the sample workload is small, because for each individual it will take the electrophoresis machine will take 2 samples and take time for performing. So it's a little bit time consuming. You need a trained technician. It is semi-quantitative. It cannot accurately quantitate the result, but still you are able to pick up sickle cell disease with the help of this technique. Then comes upgraded version of this cellulose acetate electrophoresis technique, which is a microchip based cellulose acetate electrophoresis Gazelle. This Gazelle is a small equipment, you can see, which has an inbuilt analysis software, a chip which can quantitate. So it is basically principle is a cellular acetate electrophoresis, but these bands in a simple electrophoresis machine you have to cut the bands and quantitate, whereas in this you can directly quantitate because it has a microchip which can measure the quantity, measure the different bands and give you percentages of different hemoglobins. And it has an added advantage that it has an electronic data storage and the wireless data transmission capacity so that you can send the reports to the expert. This is the kind of report that is generated using this machine. The machine can be battery operated, so it can be used in the field. However, you need a kind of trained technical person to operate the machine because it has a special, you need to prepare the blood, add it in the, load it on the cassette, and the cassette needs to go into the machine carefully. And this requires an expert technical hand to perform this test. So, though they are claiming that it is a point of care test, probably we may not say that it is actually a point of care test by definition, but it can definitely be used at the peripheral centers. One limitation of this test that when we tested it was not suitable for newborn screening because measurement of smaller quantities of food any component of hemoglobin, especially HbS when it is in small quantity, and HbF could not be measured accurately by this machine, and that is the reason probably not suitable for newborn screening. Then comes techniques which can accurately measure different components. So these are quantitative tests which can accurately measure the different components of the hemoglobin in an individual. And one is capillary electrophoresis. This machine is also available in India and marketed in different places. And this is suitable for accurately measuring different components, including HbA2, and hence useful for antenatal screening, where you want to also detect thalassemia carriers. Then comes high performance liquid chromatography or HPLC, probably a system which is being most extensively used in India for diagnosis of hemoglobinopathies, and probably many centers have maximum experience of handling this machine. It is automated system. Sample processing takes less time. You just have to load the samples, and at the end of short time interval, you get the results. Results are accurate, and the system is extensively validated. So this is one of the systems that is used as gold standard along with molecular techniques for diagnosis. Whichever tools that you use for identifying the hemoglobin variants, eventually the confirmation of hemoglobinopathy or sickle cell anemia needs a molecular diagnosis. Now for molecular diagnosis, there are two things. One is identification of a sickle cell disease. Second is for other hemoglobinopathies, whether you want to identify or diagnose along with sickle cell disease. If it's a simple sickle cell disease detection, then enhanced PCR or PCR-RFLP is useful or it is sufficient. But if you are thinking of sickle beta thalassemia and you want to look at additional molecular defects which cause thalassemia, then a multiplex PCR, a reverse dot plot, kind of things where you can look at along with sickle cell mutation, other few common mutations, that also is very useful. Finally, we go ahead and do Sanger sequencing only in cases where you really want to give probably a prenatal diagnosis. You can resort to Sanger sequencing kind of techniques. Now people are using short panels, small panels, and using next generation sequencing for diagnosis of hemoglobinopathies. So what they do is, along with the thalassemia, they also analyze after thalassemia other hemoglobin variants, and they also look for actually other genetic modifiers that can modify the disease severity. So those are also now becoming popular, especially when we are managing the cases with hemoglobinopathies. So now, so you know that there are battery of tests that are available at your disposal for diagnosis. Which one to choose for what purpose? So one of the primary objectives or one of the important components of the elimination mission is doing screening and identifying as many sickle cell disease patients as possible. You have different age groups that can be screened at different levels. So NHM has defined actually who can screen which target group should be screened and what is the purpose of screening these and what approach should be followed. So you have newborns or infants. It is very important that in a high prevalent region we have a newborn screening program that is initiated because we want to diagnose these children as early as possible and initiate comprehensive care. And the methods that can be used are either HPLC, capillary electrophoresis, or even now CPFS. Then again, children between 6 to 10 months, 10 years, 6 months to 10 years of age, again, because you want to diagnose them early so that comprehensive management can be initiated early and you can prevent lots of morbidity and mortality that you see eventually in these children. Adolescent screening and premarital screening is primarily targeted to prevent marrying individuals who are carriers of sickle cell disease and prevent the birth of an affected child. So these are the two important screening, adolescent screening, premarital screening are important in terms of preventing birth, actually in actual reality controlling sickle cell disease. Antenatal screening is also a step further in the same direction. When the mother is pregnant, you actually screen the mother. If mother is positive, found to be positive, you go ahead, test the spouse, and if both of them are affected, you do a prenatal diagnosis. Prenatal diagnosis, of course, needs molecular techniques and need to be done at a tertiary care reference center. So these are three important components where actual prevention, they need to be targeted for actual prevention. Then the seventh one that has been described is cascade screening, and this actually works really beautifully if you eventually want to prevent birth of an affected child. How is because if a family has already one affected member with a sickle cell disease, a child with a sickle cell disease, they are already sensitized to the problems that the child is facing and they are more receptive for screening as well as for the genetic counseling that needs to be given to the family. So cascade screening is another important and effective way of screening and sensitizing people. Then there are other important sites for screening and diagnosis at various level of care that have been also defined. For the sake of time, I'll not go into the details, but which facility should have what kind of tests and who should be performing is also been defined by the guidelines. Then now I focus on some four of these important aspects that one is newborn screening. Newborn screening, when it is to be done, how it is to be done, and which are the methods that are to be used. So for newborn screening, either you can collect the cord blood, or if you are not able to collect the cord blood, you can also, while the child is still in the hospital, you can collect a dried blood spot by just giving a small prick with a needle. So by quick technique, you can collect a dried blood spot, which can be then further tested either using point-of-care test or HPLC, capillary electrophoresis, or isoelectric focusing. Then for antenatal screening, you need to be more accurate. You don't have time for doing the screening test and then a confirmatory test. Along with sickle cell disease, you also want to diagnose that the mother is a carrier for thalassemia. So one prefers to do a more gold standard test upfront, especially HPLC in these situations. If HPLC is positive, it means do a molecular confirmation. Also test the stocks and prenatal diagnosis. Then population screening. You can do population screening using, if the prevalence is not very high, you can use a solubility test, or you want to be more accurate, then use LFI based tests for population screening. Then in a hospital setting, if you have an urgent bedside diagnosis, required point-of-care test can be very useful. It can be done at any time of the day and you don't require a technician. But all this diagnosis must be then eventually confirmed on molecular test. One important message that I would like to give here is whatever we use for a mass screening, tools for mass screening, it is always recommended that during mass screening program, if you find anything abnormal that needs to be confirmed again, by calling the patient, either by using the gold standard methods like HPLC and if possible molecular testing. So, last 5 years, in newborn multi-center newborn screening program in India. So we had screened, our center was coordinating this activity, and we had 7 centers across 6 districts in India, and we screened nearly 70,000 patients in this over a period of 5 years, and identified like 29 newborns, which we went ahead and tried to follow. The follow-up could be possible in 90%, which is a very good number. So we could follow up around 429 children and include them in the comprehensive care and follow them up for a period. And those children who crossed 2 years, we also started them with hydroxyurea therapy. So the challenges, I would just like to highlight the challenges probably we want to discuss this, because one of the problems that we faced was tracing the children back, because many times the mother comes to her mother's house for delivery and then goes back, and then tracing the mother to the child sometimes becomes challenging as the address is not adequate, mobile numbers are changed, or accurate mobile number is not correct. And we could not, 10% of the children, we could not actually either trace back or include them in the comprehensive care, because in some proportion, at least around 5% of the newborns, we could not convince the parents in spite of having a good counselor, the good facility and an entire team. Largely because there is still a stigma associated with the diagnosis of the disease. Another challenge that we face, because newborns look really healthy in the beginning. So not even a doctor, but the treating clinicians are hesitant in initiating, especially antibiotic prophylaxis and then hydroxyurea therapy. What we have seen is that many of these children, the symptoms actually start after 15 years of age. And till that time, doctors and parents are, unless they've seen a child being sick, they don't want to start the child on antibiotic or maintenance hydroxyurea therapy. So that is one challenge where we have refusal, especially for antibiotic therapy from the diabetes. Second, another important is the physical distance. I am sure NHM is addressing this issue. We will have till the periphery, the centers will be able to give care to these children as well as follow up these children, especially if it is a basic CBC and LFT. RFT can be done at the nearest healthcare facility. That would be wonderful.
Ma'am, if we can little bit expedite, please.
Okay. So then I think these are the challenges that we face and probably need to be addressed. For antenatal screening, again, the similar challenges that we had late reporting of patients for ANC, difficulty in convincing spouses, and reluctance to travel long distance again for testing. So these are all the challenges that I thought I'll put, so that we need to address these challenges now, which we have experienced through our experience of large scale antibody screening, newborn screening, as well as hydroxyurea therapy. I think management, if we have shortage of time, I will skip management part of hydroxyurea therapy. Only thing that I would like to stress, and Dr. Diptijay Madam also has stressed, that there are certain tests and investigations that need to be done on a regular basis to monitor these patients optimally. And this is something probably needs to, as for thalassemia, we have included in the MJRA package. These investigations need to be considered for sickle cell anemia, sickle cell disease patients. So I think with this, I will stop here. I would just like to share that we are happy that our Center for Research Management and Control of Immunology was inaugurated last year in December 2022 at Chandrapur. And this year, actually, to celebrate the first year, we are having a big international conference to address various aspects of sickle cell disease. We have around 10 international faculty, and this conference is going to be on the 4th to 6th of October. And a big thank you to all of you once again for your patient hearing. Thank you so much.
Thank you so much. Thank you for the nice presentation. It was really nice. Actually, to know, and the last slide was very important because what we need to include is more important. And this will be, I think, we would like that you please share your presentation. You have already done it. But it will be better that it be shared again. And the most important, one more thing, Dr. Tulika wants to say something.
Yeah. So thank you, Dr. Manisha. It's always such a pleasure to hear your talk. I think that there was one slight thing which you may have inadvertently said. So the gazelle cannot be used for newborn thalassemia screening, because thalassemia screening, as you know, newborn, it cannot be done. But there are now several publications, and we know that gazelle can be used for newborn sickle screening. In fact, it can even be done in premature babies up to 37 weeks gestation. So just wanted to highlight that because we have a very wide group and we didn't want to have anything going. Thank you again. Really wonderful talk.
Thank you.
Thank you so much.
I am sorry about that because we had done testing a few years back when it was initially launched, and that time that was the limitation. I am sure they have addressed it over the years.
Yeah, so with your suggestion, it has been addressed actually. With your suggestion, it was addressed, and now they are coming up with more tests and all. So anemia can also be tested, and hemoglobin E as well. So over to you, Dr. Rahul.
Actually, the point of care device has really changed India. When you see within India, you don't see anything. When you sit in Togo and you see India is almost like America. Okay? So I think I should applaud everybody, Dr. Manisha. Your hard work for years together is commendable. Deepti Jain ma'am, Vinita Srivastava ma'am, Tulika ma'am, Shubha Tuli ma'am, and all of us has worked really hard to know where we have reached India. When I speak to my colleagues in West Africa, they have got no access to point of care devices, and still they see the dimension of science from the world view is from either from France or from US, which is like 100 times more expensive and cannot be the reality and cannot reach to the mind. तो दोस्तों हम जो अपना व्यू और डायमेंशन देखते हैं वो अफ्रीका के एक व्यू से देखते हैं जो कि कैपिटलिस्टिक पॉइंट ऑफ व्यू है, बट मैडम के व्यू से अगर देखा जाए तो डायग्नोस्टिक्स जो हमने शीर्षता हासिल करी है पिछले 2 दशक में वो सही में नमन करने योग्य है, क्योंकि हम आज किसी भी चीज का डायग्नोसिस बना सकते हैं। और इसी कड़ी में आज जेनेटिसिस्ट और जेनेटिक्स ऑन्कोलॉजिस्ट मॉलिक्यूलर ऑन्कोलॉजिस्ट have started to do we just got the next generation sequencing machine GenX, which can give the genetic diagnosis within 3 days. So I think it's a great initiative. Moving on, and thanks Dr. Manisha for keeping in time. Moving on to the next topic. Dr. Anupam Sardeo, our country knows him. He is the Bhishpitama for hematologists, for pediatric hematologists. All his students are doing so very well in the country. I would like to invite Anupam Sardeo sir, and the honor to listen to him. The management strategy for sickle cell disease, of how and what we have done and innovated in India. And another request, just keep it in time, 20 minutes, so that we can finish in time.
Thank you very much, Rahul. Will you please share the slides and put them on? Now, we know that sickle is a point mutation in which the deformability of the red cells is deranged. They turn into rigid sickle-shaped cells and get sludged in the vessels. In addition to that, now we know that with sickle cell disease, there is a degree of inflammatory processes which are going on in the endothelium of the vessels, which leads to further problems and thrombosis, etc. So that is what the sickle cell pathophysiology is. And we also have what we call as compound sickle, in which you can have beta 0 sickle, you can have HBD and other hemoglobins combining together to form a compound hemoglobinopathy, and that leads to further problems. Next slide, please. Next. So once you have that, a disease which will affect the blood cells would end up affecting almost every organ system. And when it affects every organ system, it leads to what we call as, I call that as effect of diabetes kind of a disease, where you have effect on the brain, you have effect on the eyes, you have effect on the heart, on the lungs, on the spleen, on the liver and the biliary system, on the genitourinary system, on the musculoskeletal system, on the bones in the form of AVN of the hip joint, etc., dactylitis in children, and so on and so forth. So almost every organ system will be affected with sickle cell disease. And once that is affected, we obviously have to strategize and put things in place so that the follow-up of these patients also includes almost every organ system, maybe not initially, but later on in life, at say 6 years or 12 years of age, every organ system needs to be checked, and we need to have strategies to prevent and to ameliorate the damages done by sickle cell disease as such. So that is what I feel we should be talking about, and as Dr. Dikti also said, that now across the world, we don't call it as sickle cell anemia, we call it as a sickle cell disease. So obviously what it means is that when you are having a disease which affects every organ system, a sickle cell clinic will also not be limited to a hematologist or a pediatrician. It includes an ophthalmologist, it includes a cardiologist, it includes a gastroenterologist, an orthopedician, a physiotherapist, and so on and so forth. And not to forget the involvement of the lay public, the teachers, the educationists, etc., to help ameliorate the disease. Next slide, please. Okay. So I've already talked about this. Almost all the complications of sickle cell are delineated there. Next one, please. And in a diagrammatic fashion, as you can see, the whole body system is involved. You can have stroke also, you can have vascular problems. So we need to look at it from every aspect. Next slide, please. What are the treatment strategies which are included in this condition? One is that you must take care or prevent infections. So obviously another dimension comes in is the need of an infectious disease specialist also. We also need, and not to forget, Tulika is smiling because she is a pediatrician and she wants me to put in the word that a primary pediatrician also is absolutely essential, not only to make the diagnosis and send the patient early, but also to look at the vaccination and especially pneumococcal and other vaccines which are special vaccines for these patients. So we look at it from all angles and we need to look at it also from the angle of a nephrologist, because with a nephrologist you need to have to know this thing that you have proteinuria and hypospanuria in patients of sickle cell disease, which can cause not only sickle cell disease, sickle cell trait patients later in life can present with renal carcinoma. So that is also very important. So it's not just the disease patients, the trait also are affected. We need to put in penicillin prophylaxis early in these patients because that can prevent infection, and we have enough trials in the form of PROS1 and PROS2 trial to look at penicillin. We need to have pneumococcal vaccine if you are in the newborn period or in the infancy. 3 doses of pneumococcal vaccine have been recommended by the ACVIP, CDC, as well as the IAP. We need to think of putting in hydroxyurea. There are different, concepts about it. Some people say that with the baby hug trial, you can start hydroxyurea early on in life, even at 9 months to 12 months of age. But others are a little skeptical because they are scared that in a country like India, where the follow-up may not be that good, you may have to be a little careful and maybe you can start the hydroxyurea a little later at 1.5 to 2 years of age. We also need to look at our own indigenous, what we call as the therapy which we need to put in. For example, people in the West start with a dose of 10 to 15 milligram of hydroxyurea, up it every 4 weeks, follow it up with counts, with the liver function test, renal function test, and then slowly increase it to the maximum tolerated dose of 35 milligram per kilogram body weight per day. Now, in our country, what we have found is that a minimal dose of 10 to 15 milligram as a single dose, which may not require that much of follow-up, that much of coming back to the hospital for the counts, etc., may suffice, and it works very well. And Dr. Deepti Jain, who has worked on this aspect, has shown that it does make a difference. We need to add, the folic acid, 2.5 milligram for earlier on, and then 5 milligram. Transfusions to reduce the HPS levels below 30% are also required in cases where a stroke or a decrease in cognitive functions, etc., have occurred, and it is also required in patients with sickle cell anemia. Other important care strategies are, as we say, folic acid, counseling for complications and need for regular health maintenance checkups, need for using of hydroxyurea, avoid dehydration. Febrile episodes must be attended to immediately and with weight, vigor. Nutrition is important and may help reduce the growth inhibition seen in SCD patients compared to their siblings. Now, we need to look at our own country and our own traditional nutritional diets, which were much better and much suitable for these patients. So we don't have to look at the best that we need to add proteins and we need to add other things. There are enough things in our diet in the form of ragi and other plants and herbs which do help in these patients. The patient should also receive, in case there is any proteinuria, they should receive ACE inhibitors, and in case the proteinuria is very high, then the ACE inhibitors have to be stopped. Now, coming to what are the indications for hydroxyurea and sickle cell disease, patients who have moderate to severe episodes of crisis need to be on hydroxyurea. Patients who have acute chest syndrome, have stroke, etc., need to be on hydroxy. Although the switch trial, which compared traditional transfusion therapy with hydroxyurea, didn't show much of benefit with hydroxyurea by causing a decrease in the transfusion requirements. Sorry. Now, what are the points to be evaluated when you are putting the patient on hydroxyurea? The point is that, as I said, that you need to start with 10 to 15 milligram per kilogram body weight. If you are going by the increasing dose, then 5 milligram every 4 weeks with a proper count and a LFT as well as the RFT, followed by an upping till you achieve an HP, a rise in HPF, although at times you may not get a rise in HPF also. But basically we need to maintain the platelets above 1.5 lakhs, a count of more than 2,000, and a retic count of more than 80,000 in these patients. If you get a fall in these, then you need to stop the hydroxyurea, wait till the counts have risen up, and then start at a dose which is 5 milligram lower than the previous dose which was given. So that's how we monitor the hydroxyurea. We also can give, as I said, a single dose, minimal dose of 10 to 15 milligram per kilogram body weight. Now we have a syrup of hydroxyurea available. There is a 200 milligram tablet of hydroxyurea which is available and is marketed by Novartis, but it's yet not marketed in India. But you can actually prepare a solution of hydroxyurea and keep it for about 9 months or so when you are using in these patients. Now, dose-dependent toxicities of hydroxyurea are thrombocytopenia, anemia, thinning of hair, nausea, anorexia, etc. My pharmacology teacher always said that if you don't know the side effects of a drug, just say nausea, vomiting, and diarrhea, you may be okay. And if you still want to go a little ahead, say allergic reactions, you've done the job. But in this case, we need to look at diarrhea as a very serious thing because it can be because of low counts, and we need to look at low counts and infections in these cases. Very rare, we see less than 1% or so, we see allergic reactions, leg ulcers, increase in treatment, increase in SGPT, and that's why we say initially we must monitor the LFT and RFT. Non-dose dependent are skin pigment, hypopigmentation and pigmentation. So, how do you monitor the patient? Patient comes, I have and taking hydroxyurea. You're not sure, you have not seen an increase. So first tell him to bring his strip and see if the strip is empty or not. The patient may be smarter than you and may still take out the capsules and put it on one side and come with the strip. Then you do a blood count, and you must look at the blood count with the MCV, because in the hydroxyurea you get a rise in the MCV, you get a fall in the hemoglobin, in the TLC and the platelets, and along with that you can look at the HPLC and see if there's a rise in the HbF levels also. So this is one way of looking at this thing. Now, in addition to all of this, I'm not stressing too much on counseling because Dr. Deepti Jain has already done it a number of times and has said that counseling is very, very, very important and there is no getting away with this. And next slide, pediatric antibiotic prophylaxis. For the younger children, somewhere around 75 to 80 milligram of penicillin is enough twice a day. But as they go above 1 year, it is 125 milligram twice a day, and so on and so forth. And you can keep on increasing. Then it is said that those who are on penicillin prophylaxis for about 5 years, you can probably take it off. But if you have a splenectomy done, maybe, or you're thinking of, then you may have to give it lifelong. In addition to that, those who are sensitive to penicillin, they must receive erythromycin in case they are the same. Now, pneumococcal vaccine for prevention. Remember that the conjugated pneumococcal vaccine is now a part of the immunization program of the government of India, at least till the age of 5 years. Now, this is where we have to come in, and we have to advocate that people who have yet not received the benefit of pneumococcal vaccine and are above 6 years of age need to be given the pneumococcal vaccine conjugate. The problem is that all the vaccines which are available to us as conjugate vaccines, which are Indian vaccines, are not tested for people above the age of 5 or 6 years. This is where the government of India has to come in, that it should ask the companies to go ahead and get the vaccine approved for children above 6 years of age also. Now, after the initial pneumococcal vaccination, we need to give them the pneumovac polysaccharide vaccine, 1 dose after the age of 2 years and another dose after the age of 5 years later on. Now, it is very important that every patient of sickle cell disease is properly followed up and a proper health maintenance program for the children with sickle cell disease. So, for those who are on hydroxyurea, initially every month follow-up, and then later on every 3 months or so with their blood counts and the LFT, etc. For those who have, for other patients, 6 monthly follow-up of these patients is required with a proper recording in the diary for their complications. After the age of 6 years, pulmonary function testing, at 10 years or beyond 10 years, cardiac function testing, MRIs in case you are thinking of a stroke or you have subtle cognitive defects, then also an MRI is required, because a lot of these kids do not have overt strokes and have subtle cognitive defects. In addition to that, a transcranial Doppler examination should be done, and the magic figures are 170, 190 and 200 plus. These are the magic figures. Any patient who has more than 200 ml per second needs to be looked at and more frequently. Similarly, children between 170 to 200 also require more close follow-up with the TCT. Even fall in the level of the velocity of the speeds in the middle cerebral artery is also a very important thing, and we need to look at that also in a big way. Now, I'm not going to delve into the screening tests and all, but basically, you must remember that the diagnosis is either by electrophoresis or by HPLC. Now, we know that even isoelectric focusing can be used, and HPLC can also be used for newborn screening. But we also have to look at veno-occlusive complications, and we have to manage them, give hydration, use other methods like giving transfusions, etc., and managing them. Management of pain, as Dr. Tulika reiterated, and Dr. Singh, is also very important. We usually do a step-ladder fashion of management of this thing by starting with paracetamol, then adding NSAIDs, then going on to tramadol, etc., and lastly morphine or opioids. We can also at times use Linctus Codenaco in these patients, because although it's marketed as a cough syrup, but it can be used for this thing. Treatment and follow-up of acute pain is very important, and we must see that the acute pain does not turn into a chronic pain syndrome, and we should take care of these patients. Acute chest syndrome is very important and needs to be differentiated from infection in the chest as such. But when you have a sickle cell disease patient, first suspect an acute chest syndrome and then think of infection. But anyway, both the things will require antibiotic therapy. Blood transfusion support. This is again very important, and as Dr. Deepti said, that children with hemoglobins less than 7 need to be looked at, and also those with stroke and with other complications, we should give blood transfusions and we take care of them. But at the same time, don't overdo things. In thalassemia, for example, we take it up to 13 or so 14, but here we don't overdo it and try not to go beyond 10 or 11. As far as pregnancy and this thing are concerned, it is very important that in pregnancy we should, when the patient is going to labor, first of all, before she gets pregnant, at least 3 months before, hydroxyurea should be stopped because it can have teratogenic effects. And number 2, during pregnancy, proper folic acid and even pre-pregnancy folic acid should be given. The patient's hemoglobin should be kept around 9 or so, and adequate nutrition should be taken care of. During labor, there is nothing specific. We don't need to go in for cesarean section for sickle cell disease. We need to look at sickle cell disease as a condition in which normal delivery can be conducted, but at the same time, if there's an obstetrical indication to do the cesarean section, please go ahead and do it. Number 2, in any pregnancy, at the time of parturition, the hemoglobin should be at least 9 to 10 grams per deciliter. During surgery, during labor, adequate hydration should be maintained, otherwise you are going to be in trouble. During surgery, for example, we try to not give general anesthesia, we try to give them local anesthesia in the form of spinal, etc., so that we can prevent unnecessary hypoxemia during cesarean. Avascular necrosis of the femur head is also an important thing. The key thing is to give rest, take care of the hydration, take care of the necrosis before it becomes too bad, and then we have to go in for hip joint replacement. Central nervous systems problems are again very, very important, and they lead to a major effect. There is an algorithm for stroke which are available in next slide please, for stroke for algorithm for stroke in children, and similarly there is an algorithm for adults also. Treatment of TIAs in SCD are usually treated with acetyl salicylate or aspirin. The usual dose is 2 to 3 milligram per kilogram body weight, and warfarin can also be used in severe cases, but you have to be careful because it can lead to things also. Cardiac complications come in the form of 2 forms. One is pulmonary arterial hypertension, caused by repeated thrombotic events, and the other is by increased ferritin, which will cause congestive heart failure. For increased ferritin, we need to start the chelation before it crosses 800, 900 nanograms per ml of ferritin, and for PAH, we need to give ACE inhibitors, etc. So we have an algorithm for the management of hypertension in the sickle cell disease. I won't go into the details of the algorithm. They are available on the various sites also. For the genitourinary system, we must remember that it can cause priapism, although it's not as common in India as it is in the West, in the African continent. But the key thing is hydration, rest, phenylephrine, and other things. And in case it does not go down by 3 to 4 hours, it needs surgical intervention. Ophthalmic problems in sickle cell disease can occur in the form of a retinopathy, just like the neovascularization, and requires treatment by a person who is trained to handle retinal detachment, retinal hemorrhages, and proliferative vasculopathy. For the retinopathy, we need to start screening at around 10, 11 years of age. So friends, as I said that the sickle cell disease is a disorder. I would say it's a disorder which affects almost all organ systems. And we need to involve and have multidisciplinary care, and it cannot be one man handling everything. It has to be a team which handles it. Thank you very much.
Thank you, sir. Thank you so much. It was really great to hear the session actually, and the management part has been well taken care of. Over to you, Dr. Rahul. So we have heard that what management practices should be followed up in the hospitals and what is important. This was very a comprehensive presentation, Dr. Sachdeva, which has been given, and I can hear from the audience that they are very happy to hear what you have said. And we will try to accommodate all those necessary things which are important for the patients, and so that the patients also get benefit out of it. The division of packages are meant for this, that we need to know that what exactly is required currently. Because in sciences, it's not only ki one thing is there and another thing comes up in few days. So that's very important, that to incorporate new things and new medicines, whatever it is required, that's very important. So now, Dr. Rahul, are you there? Dr. Rahul, are you there? It's yours. Manisha?
Yeah, I think it's just.
So while I think Dr. Rahul is having some technical issues, so happy to hand over to Dr. Gaurav Khalia, who's going to give his insights on bone marrow transplant. Over to you, sir.
Before that, we would like to say that Dr. Khalia has been working in Apollo and has done around 100 transplants altogether. 160. I mean, it's a big number for blood disorders patients. So this is a time when we should hear what exactly is it that the BMT meant for SCD, and how it has to be taken up in the coming years. Thank you.
Thank you, ma'am, for having all of us here. And I mean, this was, as Rahul highlighted earlier, also this was a, as highlighted earlier by Rahul, this was a much awaited session, and as I always say that sickle cell disease, not only in India but globally, it has been a neglected disease, and it's good to see that it is gaining the kind of attention which it required for such a long time, but it was missing. So we have looked at the various aspects of sickle cell disease, right from the diagnostics, prenatal diagnosis, by the experts, by Dr. Deepti, Dr. Tuleka, Dr. Sachdeva sir. Now we'll move on to one important aspect. I mean, when we talk about any such chronic disease, whether it is thalassemia or sickle cell disease, there are two sort of ways by which in which we categorize the management of these patients. One is care, and another one is cure. So care is the routine care which we give for these patients in the form of medications such as penicillin, hydroxyurea. But when we talk about cure, the only curative modality at this point of time which is available is bone marrow transplant, awaiting gene therapy, which is available in some parts of the world, but unfortunately it's not available in majority of the world, and even if it becomes available, unfortunately the cost will be prohibitive unless we come up with some indigenous solutions. So what I'll do in next 10 to 15 minutes, I'll just try to quickly take you through how the transplant started, what is our experience, because India-centric experience is more important when we talk about transplants, and then subsequently we'll just move on to quickly to futuristic modalities such as gene therapy, and then sum up and move on to the question answer sessions. So move next slide please. So overview of today's presentation. So we'll go into the history, epidemiology, pathophysiology, current therapeutic modalities, transplant background, what is our experience of transplant, how we have evolved over a period of time, and then finally we'll sum up and move on to the question answer session. Now, when we talk about sickle cell disease, it's not a very old disease. So this disease is almost a century, is around a century old. The first sort of notification of sickle cell disease was made roughly around 1910, when this physician by the name Dr. James Hendrick, he noticed that there are some abnormal or some weird findings in the peripheral smear of one of his patients who happened to be a medical student as well. He was from African descent. So Dr. Hendrick repeated those peripheral smears multiple times, and every time noticed that similar finding. At that point of time, he said that it might be because of some kind of chemical reaction which has happened. But later on, it was attributed to some new form of disease, which was further detailed in a molecular way by the famous chemical biologist Dr. Linus Pauling, and subsequently Dr. V.S. Ram further differentiated the molecular nature of sickle hemoglobin versus other forms of hemoglobin. While all this thing was happening, a lady pediatrician who was working in Brooklyn, New York, she made a very interesting observation that the kids who are born to mothers suffering from sickle cell disease, and eventually they also develop sickle cell disease, they are protected by from sickle manifestation, whether it is veno-occlusive manifestation or other manifestations in the initial years of life, especially the first year of life. And at that point of time, we thought that it is because of some different form of hemoglobin which is present in these patients, in these infants, which prevent them from these sickling related complications. And it was further substantiated by this large study on almost 2,000 patients and published in NEJM, which showed that if the patients have a sickle hemoglobin of more, or fetal hemoglobin of more than 8.6%, they are relatively protected against sickle related manifestations. Moving ahead, we have moved further. I think we'll have to go back 2 slides. Can Can you move to the slide? Yes. Next slide, please. Next slide, please. Yeah, when we talk about the sort of developments which happened in sickle cell disease, I would like to mention Dr. Vijay Sampton, who's Indian by origin, practicing and a pediatrician and a pediatrician turned researcher, practicing currently in Boston. He is the one who actually detailed the way by which the fetal hemoglobin switch happens, or the hemoglobin switch happens from embryonic hemoglobin to fetal hemoglobin to adult hemoglobin. And this has paved the way for many sort of therapeutic modalities, whether it is induction of fetal hemoglobin or various gene therapy or gene manipulating modalities. Not only this, he also highlighted the role of an important marker, which is BCL11A, that how if we modify this BCL11A functionality, how we can sort of make the patient or cure these patients of either sickle or thalassemia related manifestations. Next slide, please.
Just a second, can you see the PPTs? Imagine?
नहीं,
Can you see the PPTs?
you'll have to share the screen again.
Is it visible now?
Yeah.
Huh?
Yeah.
Okay, sorry. Sorry, I think a few slides have been missed earlier, but I think I was, no, it's okay. I think it was more of an introductory slides. We'll move on further. Yeah, next slide, please. So, looking briefly into the epidemiology of the disease, so we can very clearly see in this picture that the burden of sickle cell disease is the highest in the areas where the endemicity of malaria is the highest. Okay, next slide, please. Again, a very important slide. This cardiogram shows the burden of this disease in 2010 and the expected burden of sickle cell disease in 2050. So we can very clearly see that the expected burden of this disease across the globe is expected to go up, and if we make full-on effort starting from now, then only by 2050 this disease is going to, the burden of this disease is going to plateau down. So this is very, very pertinent because we have to have a holistic approach in sort of bringing down the burden of sickle cell disease along with the supportive care modalities and the curative modalities. Next slide, please. Now, this is a brief about the pathophysiology of the disease, so I think I'll skip this slide. We all know about the pathophysiology of sickle cell disease and subsequent complications which happen. Coming to the therapeutic modalities, so Sir has nicely taken you through the therapeutic modalities which are available. Broadly, so when we talk about supportive care, it is lifestyle modifications with some important medications such as penicillin, hydroxyurea, Voxetor and Crizan. They have come up recently, but the usage of these patients or experience with these drugs, especially in Indian patients, is very, very limited. But when we talk about the curative modalities, awaiting gene therapy, transplant is the only treatment for curative modality available. Next slide, please. Next slide, please. Now, going through the background of transplant for sickle cell disease. So the first manifesto, first clinical report of transplant for sickle cell disease dates back to 1994, when a young patient who was suffering actually from acute myeloid leukemia, a blood cancer, with an underlying diagnosis of sickle cell disease, when she received a transplant from her sibling donor for acute myeloid leukemia, subsequently it was seen that she was cured of her manifestations of sickle cell disease as well. And this paved the way for this thought that, okay, if we do transplant isolated for sickle cell disease, we can cure a number of these patients. Next slide, please. So, looking at the EBMT Europol data, so this is a relatively old data, but if we talk about the updated data, around 3,000 transplants have been done for sickle cell disease across the globe so far. Next slide, please. Now, if you look at the total number of transplants which happen every year and the number of transplants which have happened for sickle cell disease is a huge gap. So Every year, around 100,000 transplants happen for different diseases: thalassemia, sickle cell disease, thalassemia, aplastic anemia, leukemia, so various diseases. But in past, and the transplant has been happening since 1950, 1960. So in past, say, 50 to 60 years, just 3,000 transplants have happened for sickle cell disease, which is a very minuscule number. If you look at the number of patients who actually need transplant, in Europe and America, approximately 40,000 patients have clear-cut indications of transplant but are not being transplanted because of one or other reason. If you look at the number of, if you include the number of patients from African continent, from Middle East and from India, the number of patients who actually need transplant is countless. Next slide, please. Now, what is the difference? So why is this big gap there? So number of patients who actually need transplant, which is in millions, and the number of patients who have received transplant is very minuscule. So what are the differences? What are the obstacles in pursuing transplant as a curative modality? So these are the main challenges which I have seen by working in transplant for sickle cell disease for past more than a decade. So first of all, there is no clarity about the indications. So what are the clear-cut indications? Who are the patients who actually need transplant? Secondly, the awareness is not there. So there are a lot of apprehensions, especially even in the physicians. If I talk to my pediatric colleagues from Chhattisgarh, from Madhya Pradesh, a number of times it is very surprising to know that they don't even have the idea that the outcomes of sickle cell disease transplants, if we do at the right time, using the right donor, the outcomes are more than 90%. So that is the lack of awareness among the physicians, and subsequently, once they are not aware, they don't pass it on to the parents and the patients. Lack of funds, which is a very important aspect and becomes even more important in resource limited settings. But with the help of all the interventions which we have talked about through NHA and other government and non-governmental agencies, other CSR projects, I'm sure this challenge will be able to address to a significant extent. Now, if you look at the indications, so this is the most sort of comprehensive list of indications which I think all of you should go through. That is a publication which has used these indications. These are the latest indications from 2012, 2014. And if you look at these indications in our Indian patients also, I have seen that approximately 1/3 of the patients who are diagnosed with sickle cell disease are candidates for transplant. Next slide, please. Next. Now, looking at the group of transplant for sickle cell disease, so this is the CIBMTR data analysis looking at approximately 1,400 patients for sickle cell disease. Yeah, move on. Just complete this slide. It's yeah. So if you look at the transplants, so actually identical donor transplants from sibling donor, unrelated donor transplants, or haploidentical donor transplant. So it is very clear and it is obvious that the patients who receive a sibling donor transplant, they have the best possible outcomes. Vis-a-vis patients who receive a half match transplant, the outcomes are not as good as full match transplant, full HLA match transplant. So the problem area is to optimize the outcomes of haploidentical transplants. Why is it so? If a patient needs transplant, suppose if I need a transplant, I have one brother. Now the chances of my brother being a HLA match is just 20 to 25%. If I include unrelated donor registry also, it adds another 5-7% chances. So if I need a transplant, I only have 30% chance of getting a HLA identical donor, 70% chance of not having HLA identical donor. So this way we'll not be able to help 70% of the patients if we just focus on HLA identical donor transplant. So if we can optimize the haploidentical transplant strategies, another 70% of the patients can be offered this curative modality with better quality of life. Next slide, please. Just move to the next slide. Yes. Now that was the CIBMTR analysis. Almost the same is the outcome from our European colleagues. And if you look at the outcomes of haploidentical transplants and cord blood transplants, obviously the outcomes are not as good as sibling donor transplants. So there is a huge unmet need to optimize the outcomes for haploidentical transplants. Next slide, please. Now, haploidentical donor transplant, when we talk about these transplants, this is the landmark paper which was published in 2012 by the NIH group. And in this smaller group of patients, of 17 patients, out of which 14 underwent a haploidentical transplant, they very clearly documented that using a reduced intensity conditioning, I mean a low intensity conditioning, almost 50% of these patients can be cured of sickle cell disease. So the good point was that the overall survival was very good, more than 90%, but the disease-free survival, that means the patients who were actually cured of sickle cell disease were just around 50 to 54%. So then, but this was a very, very interesting concept which paved the way for further work in transplants, haploidentical transplants for sickle cell disease. Next slide, please. Now, just taking you through our journey, why I'm talking about our journey, because we need to have an India-centric approach for these disorders, otherwise we just burn our fingers if we just try and adopt the protocols from our European or Western American colleagues. So this was our first patient, so this was an African patient, African child who came to us for a transplant. It was a sibling donor transplant. A child was very, very unwell. He came to us, he was having acute chest syndrome. We tried to sort of manage it. He became better. We took him off for transplant. Again, underwent had acute chest syndrome. So the entire transplant went on a ventilator. But fortunately, this child is doing well. 10 years post transplant, doing extremely, extremely well in life. Next slide, please. Same year, we were able to do our first haploidentical transplant. So this was a 5-year-old boy from African descent, very, very symptomatic child. Underwent a half-match transplant using father as a donor. 10 years post bone marrow transplant, doing very well, doing this sort of 11th or 12th grade somewhere in US. Next slide, please. Now, our experience of haploidentical transplants for sickle cell disease. Next slide. So just like any sort of training comes back and start practicing, when I came back to India, I just tried to adopt the strategy which we were using at St. Mary's, where I got the training for transplants for sickle cell disease. And if you look at the original protocol by the NIH group, my mentor there made some modifications in that protocol by adding some sort of additional pre-transplant preparatory strategies. And by this, the outcomes, he was able to bring down the rejections of the graft failure rates by almost 20%. Next slide, please. So, I used the same strategy, but unfortunately it did not work for our patients. I made certain modifications and used another strategy by focusing more on the pre-transplant preparation. So that gave us a little bit better results, but again, the results were not as expected or as we all wanted them to be. Next slide, please. So with this intent that we need to reduce the graft failure rate by almost 100%, need to improve the overall outcome, reduce the risk of graft versus host disease. We made this third modification. Next slide, please. And this is a rough protocol. This is the protocol which we sort of developed and we are currently using. Next slide, please. We published these results, the initial cohort of 20 patients, very encouraging results. So, initial 25 patients with very, very encouraging results, and I'll just take you to the outcomes so we can very clearly see that the graft versus host disease was very, very less. All 100% of the patients engrafted, so they all sort of accepted the graft. Another important complication is graft versus host disease. The graft versus host disease was also very, very less, and the overall survival in this very, very sort of symptomatic group of patients was approximately 88 to 90%. So this was a big achievement. This was as good as a sibling donor transplant. Now, taking you through our overall experience of around 140, this was around 5-6 months old. So now it is approximately 160 transplants just for sickle cell disease. This is the largest cohort of transplants for sickle cell disease. I was in another sort of seminar, and overall in India around 340 transplants have been done for sickle cell disease in past 15 years. Out of which this is 160 patients which we have transplanted at our center. Now, this includes both half-match transplants and actually identical donor transplants. These are the patient characteristics, but I'll just take you through the important pertinent slides. So majority of these patients, so this is over a period of 10 years, includes all our learning experiences, the first modification, the second modification, but just taking through the cumulative results. So the engraftment is very, very robust in our patients. The average time to engraftment is 13 days, as in contrast to the Western world, where the median duration of engraftment is around 22 to 24 days. If you look at the rejections, the rejection rates have come down significantly. If you look at the right slide and the top line, that is the rejection-free survival. So using the latest strategy, the rejection rates have come down to almost negligible. We have had 1 or 2 rejections, but the reason for that is different. Okay. As I highlighted, we have used different strategies for half mesh transplant. So if we look at these 2 strategies, obviously the outcome of the strategy which we are currently using, which is called as Apollo protocol, the outcomes are much better using this protocol as compared to the previous protocol. Another very important aspect which I want to highlight here and make it pass on this message to the larger group of audience is that age is an extremely important factor when we talk about transplant. So the general consensus is that a patient should be offered transplant when the patient is having one or other significant complication or a life-threatening or a life-limiting complication, which happens as the age progresses, and majority of these patients are like beyond 10 years, 12 years, 14 years of age. Unfortunately, if I thread out my data, the patients who underwent transplant more than 13 years of age, whether it's less than 13 years of age, irrespective of the donor type, the outcomes are almost 25 to 30% different. What I want to emphasize is here that if the patient of sickle cell disease is not doing well on optimal supportive care, we need to identify these patients early and offer them transplant early in life to offer them the best quality of life and best outcome. So in our group of patients, if the patient is less than 10 years and we offer even a half mesh transplant, the outcomes are approximately 90 to 93%. GVHD rates are very acceptable, and with all the modifications which he has made, it hasn't added to any additional risk of viral reactivation, whether it is CMV or PK. So if we look at the reactivation rates, it is pretty acceptable as per the international standards. Our overall objective of transplant is to have a good immune reconstitution, because this is what will decide the overall success of transplant. So if you look at our immune reconstitution using this particular strategy, day 100 immune reconstitution is also very good. Now, based on our success of haploidentical transplant using this strategy, we thought that why are we giving more intense chemotherapy to our HLA identical donor transplants? Can't we use the same strategy for our HLA identical donor transplants, both for thalassemia and sickle cell disease? And we sort of initially did this for 4 patients and with phenomenal results, 3 of thalassemia, 1 of sickle cell disease. And then we went to the ethics committee and took permission to extend this trial for larger group of patients. And this is the data which we presented in last year APMT. I'm sorry it has not been updated. But if we look at the outcomes using this same strategy for HLA identical donor, whether it's an unrelated donor or a sibling donor or a related donor, are phenomenal. Almost 95-96% survival in both sickle and thalassemia patients. Again, immune reconstitution, as I highlighted earlier, is a very important aspect. So, immune reconstitution using these preparatory strategies for around 6 to 8 weeks prior to transplant doesn't compromise the immune reconstitution, and immune reconstitution is very good post-transplant. So the summary of our learning is HLA identical donor transplants is a preferred source. Success of haploidentical transplant is increasing day by day. Graft failure rates have come down to almost less than 5%, I would say. GVHD rates are also very acceptable. Age is a very important factor. So if we offer the transplant in early years of life, the outcomes are very good. Now, just to conclude, sickle cell disease is a preventable disease. As soon as the diagnosis is made, which is usually in the first year of life, supportive treatment should be initiated as soon as possible. A close observation is required to identify severe phenotypes, and these phenotypes So we need to identify these patients who are not doing well, especially even on hydroxyurea or other supportive care, and these patients should be offered transplant very in early years of life. And as we make transplant amenable to the masses with the help of support from NHS, various government and non-government agencies, we should also focus on other more promising approaches such as gene therapy. There are different groups working on gene therapy to come up with indigenous gene therapy solutions, and I'm sure we'll be able to, in the next 2 to 3 years, we'll be able to come up with some affordable gene therapy solutions for both thalassemia and sickle cell disease. So with this, I would like to thank you all and thank Vinita ma'am and Aniche once again for such a fantastic sort of meeting and brainstorming session, which was much awaited.
Thank you so much. It was really good, Dr. Gaurav. It was really nice. I mean, to learn about that SCD, we can do transplant for SCD as well. Then how much it is successful and what is required actually when we talk about the pre-assessment. So that is more important. So over to you, Rahul. Dr. Rahul.
So it's a wonderful session. I think Gaurav has highlighted the role of bone marrow transplant. To majority of people who still think that bone marrow transplant इंडिया में नहीं हो सकता, इंडिया में सिकल सेल का ट्रांसप्लांट बहुत कॉमनली आज की तारीख में होता है और विनीता मैम के पुराने एफर्ट से हमने पब्लिक प्राइवेट पार्टनरशिप में रखते KSI फरीदाबाद में, कॉलेज में, पटना में, बीकानेर में आज फील्ड इस बात का हमको पता होना चाहिए और हमारे को एक बात बतानी चाहिए लोगों को। मध्य प्रदेश जो सिकल सेल की बैंक है वो मेडिकल कॉलेज में फिजिकल ट्रांसप्लांट करा सकती है और ट्रांसप्लांट से अगर लेकिन 10 साल से नीचे करा जाता है जो हमारा प्रोटेस्टर उसका डेटा है 95% लोग जिसमें मेजॉरिटी ऑफ टाइम पेशेंट थे उनसे ठीक हो जाता है। मुझे लगता है कि हमको निकालने पता होना चाहिए कि ट्रांसप्लांट से सिकल सेल क्योर होता है। बोन मैरो ट्रांसप्लांट होगा ओनली क्योरेटिव मोडालिटी ऑफ सिकल सेल। जो लोग हाइड्रोक्सीयूरिया पे ठीक नहीं हो पाएंगे उनको हमें आगे बढ़ के ट्रांसप्लांट ऑफर करना चाहिए। इसलिए आयुष्मान भारत और बोन इंडिया जैसी संस्थाएं अग्रणी तरीके से काम करेंगे। Thank you, Dr. Gaurav, for enlightening us and following the path of Dr. Vikas has been doing in the country for years together. So, coming to the last final point of it, we would request Dr. Madam Rita Srivastava ma'am to update us of what all has been done and why this whole thing was conceptualized and being beautifully executed. So over to Rita Srivastava ma'am. Every talk has been wonderful, it has enlightened us and it has paved the path for the future to role model India as the sickle cell treatment for the world. I think it's a great insight, it's wonderful. Over to Vinita ma'am.
Thank you so much, Dr. Rahul. It was really nice to hear everybody. I mean, from Dr. Tulika Seth to Dr. Gaurav Khare, it was really nice. We heard everybody, Dr. Tulika Seth talking about the thalassemia packages, what we have done at NHA, with the efforts of the specialists and the team over here at NHA. We have really come up with good packages which is going to help the patient and the health professional, as I said. And now the time is that what our additional CEO has said, that it's the time that we need to revise our packages, and I mean it may be of SCD or the cancer or anything which is required because we need updates. We need updated packages which is required for the country and the patient as well. So we heard Dr. Deepti Jain talking about the SCD supportive care. What we have heard, we will trying to include all these things are in our packages, what is justifiable and which is relevant for the country. We will try to do that. And NHA vision is to achieve the SCD eradication, that is by 2047. But the thing is that the screening, when we screen more people, we come to know about the more diseased persons. Because once the screening has started, we have come to know more diseased people are coming into the hospitals. But when they come to us, and when we see the health economics, it is important that we take care of these people. So the management of SCD will be able in the private as well in the government hospitals, both ways. And this will be helpful in all the parent hospitals and those who have these cards, those who are having these, those who are entitled for the PMJY, they will be able to get the benefits, because we understand that the most of the weaker societies has these issues and they are not able to get access to the hospitals. So now this is a time where the Government of India has taken the initiative to come up with these such packages where the dream becomes the realism. The dream is now the reality. What people used to think that we will not be able to get hydroxyurea, but now with the efforts of the Government of India and with the technical experts, with the organizations working in the field of SCD and thalassemia, these people at the patient organization has given us insight to come up with the real packages, which is really, I mean, earlier it was a dream, but not now. Now this has become a reality, which will keep up with the things, and we will be able to take our mission, SCD mission, to the new heights. Because what government admits are that by 2047 we have to eradicate, but simultaneously we have to think of the patients who are still having the troubles. So we are there with the patient, as our digital said, ki now the time is key. The government has to take much initiatives, but not alone, but with the partnership of public and private partnerships. That's very important. So we are here together, and thank you all for joining us. Please put your messages basically rather in the chat box, or you want to write to us directly, please send the messages. Everything should be sent to us. And now it's a time to say thanks to everybody, and we have Dr. Shikha with us, who is in HPQ division, and she has been very tirelessly working with us. I mean, for last 3-4 days I have been very thankful to my team, like we have Dr. Shikha, we have Vidhi, we have Himangni, we have Nandan. Everybody has been working very tirelessly to come up for this webinar, and within 3 days time it has been held, and I am all thanks to my senior colleagues over here, Dr. Tulika and Shobha ji, Anupam Sachdeva, Dr. everybody who has joined, Dr. Deepti, that because of you people now we will be able to help patients in a much better way. Over to you, Shikha.
Thank you so much, ma'am. Good evening, everybody. I extend a warm welcome to all the esteemed experts, panelists, and clinicians from across the country who have joined us for this wonderful webinar on sickle cell disease. I am honored to deliver the vote of thanks to such distinguished participants. Today's webinar has been an invaluable learning experience, and I am confident everybody has found the discussion enriching and beneficial. Firstly, I would like to express my gratitude to the leadership of the National Health Authority, our CEO ma'am, and Dr. Vasankar, ACO sir, for their support and encouragement, which have been instrumental in organizing the technical session with the participation of our esteemed experts. Their guidance has turned this event into a great success.
नहीं, जयपुर से जुड़ रहे हो, यहाँ से पेपर कैसा है? ब्लू कलर का नहीं दिखता? And यहाँ से जो
I also extend my heartful thanks to Mr. Vikram Bagaria sir, Director NHA, for his insightful briefing on ABDM and PMJY. I am grateful to Shri Rohit Jha sir, Joint Director SPC, for his comprehensive explanation about the environment of PMJY. On behalf of the entire National Health Authority, I extend my sincere thanks to all the participants for their significant contribution to today's webinar. I would like to especially thank our expert, Professor Dr. Tulika Seth from AIMS Delhi, for her vital presence and enlightened session on thalassemia packages. Very thankful to Dr. Diptijan, Dr. Manisha, Dr. Anupam Sachdeva sir, and Dr. Gaurav for their wonderful presentation in regards to diagnosis and management of disease. A special thanks to Dr. Rahul Bhagar for learning or stimulating a brainstorming session on thalassemia packages, and for taking the time for his busy schedule to share his expertise to us. I also wish to thank all the experts and panelists for their valuable inputs and active participations. A special appreciation goes to Director Chemistry Building and Principal Consultant Nilita Ma'am for her effort in making this webinar a great success. Lastly, I am thankful to all my colleagues, Mr. Nandanan, Ms. Himamini, and Ms. Vidhi for their support in making this webinar successful. I'm really sorry if I'm missing somebody's name, but I'm again thankful to everybody to make this webinar successful. Thank you so much.
Thank you, everybody, and thank you for joining us, and we will continue our discussions in future as well. So keep writing to us. This was great. Thank you so much for everything. Thank you.
A lot of people put things in the chat.
बहुत सारा